All right, so first, a little bit about me. I'm currently an associate professor at the University of Scranton, where I teach their orthopedic content. I recently retired from the Army as an active duty lieutenant colonel. I've 18 years of experience in orthopedic and sports physical therapy. And last year, I just left West Point as the fellowship director for their Division I Sports Physical Therapy Fellowship. When I was in the Army, I had a variety of clinical and leadership roles. Most of it was at West Point for the past 10 years. So I was there for 8 years as a faculty member and program director. I also worked on a health and wellness project called the Performance Triad in the Army Surgeon General's office. That was a pretty cool effort. And then I deployed to Iraq with the 101st Airborne Division. A little bit of a unique career. You can see some of those pictures there on the right. I was actually a field artillery officer before I became a PT, so I did that for 2 years in the Army. But teaching has always been my passion, so that's what I do full time now. I'm really happy to do it. So good to be talking with you guys here tonight. So here's our objectives for tonight's talk. I'll let you read through those. And then what you see at the bottom, you'll see those words bonus content on some of the slides. And so that information is above and beyond what you'll see on the clinical practice guidelines. And it may not be directly tested on the exam, but it provides additional depth and context, which is definitely going to help you answer questions and be useful in clinical practice. All right, so before we start, let's look at the content of the exam just to give you a little bit of an idea of what's coming at you. And so first, the musculoskeletal content is about 27% of the overall test. So if you look at that, it's a pretty big chunk. And then if you break it down a little bit farther, within that, um, these are some of the categories: the exam, evaluation, and intervention questions. So you can see how it breaks down there. Then when you break it out between like the big three, the musculoskeletal, neuromuscular, and cardiopulmonary, when you look at the examination portion, that's 24%. And so within musculoskeletal, you could expect about 16 questions, anywhere from 14 to 18 on musculoskeletal examination. And then in the evaluation, differential diagnosis, and prognosis area, you can expect about 16. And then the intervention area, you can expect around 17. So overall, about 49, so pretty close to 50 questions on that exam is going to be covering musculoskeletal content. So now, before we review the clinical practice guidelines, let's just go back a little bit higher up level. Let's review the relevant anatomy and biomechanics of the knee joint. So some general anatomic considerations. We have the ACL and PCL. Remember that those are intracapsular and the extrasynovial. And we have the medial tibial plateau that's slightly larger than the lateral tibial plateau, so a little bit bigger. The ACL is attached distally to the tibia on the lateral and anterior aspect of the medial intercondylar tibial spine, and it extends superiorly, laterally, and posteriorly to attach to the posterior medial aspect of the lateral femoral condyle. And it twists inwardly or medially as it travels proximally. The PCL is attached distally to the posterior tibial surface between the posterior horns of the two menisci, and it travels superiorly and somewhat anteriorly to attach to the lateral aspect of the medial femoral condyle. The MCL is divided into a superficial portion and a deep portion. The superficial portion arises proximally from the medial femoral condyle, travels distally to insert into the medial aspect of the proximal tibia, just distal to the pes anserine. And the deep portion is continuous with the joint capsule, and it originates from the inferior aspect of the medial femoral condyle, and it inserts on the proximal aspect of the medial tibial plateau. Now the LCL, that one's attached proximally from the lateral femoral condyle and travels distally to the fibular head, where it joins with the tendon of the biceps femoris muscle to form the conjoined tendon. And unlike the MCL, this one is not a thickening of the capsule, but it's a separate ligament throughout much of its length, and therefore considered to be an extracapsular ligament. The medial meniscus, this one is large and C-shaped, and it's attached to the MCL and fibrous capsule. And additional attachments are to the semimembranosus muscle and the medial meniscopatellar ligament. The lateral meniscus is smaller than the medial, and it's more circular shaped. And it's attached to the popliteus muscle, lateral meniscopatellar ligament, and the meniscofemoral ligament. Now, focusing on the tibiofemoral joint or the true knee joint, the knee is a double condyloid joint with 2 degrees of freedom. So in the sagittal plane, we have normal flexion range of 130 to 140 degrees. an extension range 5 to 10 degrees of hyperextension. The axis of motion for flexion and extension, it's an oblique axis through the condyles, and this is because the medial femoral condyle extends slightly farther distally. Now, in the transverse plane, the medial lateral rotation is approximately 35 degrees at 90 degrees of flexion, about 15 degrees medially and medial and 20 degrees lateral. There's a typo there on the slide, sorry. Flexion and extension are a combination of both roll and glide. And with knee flexion, posterior rolling of the femoral condyles tensions the ACL, and that results in an anterior translational force. And with knee extension, anterior rolling of the femoral condyles tensions the PCL, and that results in a posterior translational force. And the menisci, they serve a couple different functions. They serve to deepen the fossa of the tibia, creating that congruency of the tibia and femur, and providing stability to the tibia femoral joint. They provide shock absorption and lubrication to the knee, and they reduce friction during movement and improve weight distribution. And generally, the menisci follow the tibia with flexion and extension, and the condyles with internal and external rotation. So now let's get into the clinical practice guidelines. So the first one up is this knee ligament sprain, which was revised in 2017. So ACL injuries are very common, with 80 to 250,000 per year in the United States, with approximately 100,000 ACL reconstructions performed. The risk of ACL injury is highest in sports that require multi-directional activities, such as rapid deceleration, pivoting, cutting, and landing from jumps. Approximately 70% of all your ACL injuries are non-contact injuries. ACL injury rates are 2 to 10 times higher in female athletes when they're compared to male athletes of similar age and sports profiles. Now, depending on the clinical setting, PCL injuries may account for approximately 1 to 44% of all knee injuries. And the classic mechanism for a PCL injury is a dashboard impact to the knee during a motor vehicle accident. And PCL injuries are also common in sports such as soccer. The collateral ligaments account for 4 to 8% of all sports injuries. LCL injuries are usually a component of a more extensive posterior lateral corner injury. And then the two most common multi-ligament knee injuries involve the ACL and the MCL, or the posterior lateral corner with the ACL. And the vast majority of research on risk factors in clinical course involves the ACL. And while the majority of athletes return to sport after ACL injury, many fail to return to their pre-injury levels of competition, or they suffer from a loss of performance. Now, risk factors for ACL injuries include female sex, narrow intercondylar femoral notch size, lesser concavity depth of the medial tibial plateau, greater anterior to posterior tibio-femoral joint laxity, prior ACL reconstruction, and a familial disposition. Now, a high-quality examination of the knee combines key information from both the subjective and the objective portion. Mechanisms of injury for each of these major ligaments are different. ACL injuries typically involve cutting, twisting, or landing with a valgus load, while PCL injuries involve either a posterior tibial force or hyperextension. MCL injuries, they involve valgus force or trauma, and LCL injuries involve a varus force or trauma. In the subjective portion of the exam, patients with ACL injuries often report hearing or feeling a pop at the time of the injury. They may also report hemiarthrosis or a fusion very rapidly after the injury occurs, and they complain of giving way or a feeling of instability in the knee. Patients with PCL injuries, they complain of posterior knee pain, although the degree of effusion is not as profound as that with an ACL injury. And patients with lateral collateral ligament injuries may report localized lateral swelling of the knee. In the objective portion of the exam for all knee injuries, you should assess knee joint range of motion, effusion, thigh muscle strength, lower extremity movement coordination, and knee stability. The two best special tests for ACL injuries, those are the Lachman test for straight plane anterior instability, and then the pivot shift test for anterolateral rotary instability. The Lachman test is graded by both the amount of anterior translation present and the end feel. So it's essential to perform all these ligamentous stability tests on the uninvolved knee to accurately gauge the normal laxity for the given patient. While the Lachman test is usually well tolerated, even acutely after a knee injury, it's frequently difficult to get the patient to relax enough to perform a pivot shift test effectively. And those surgeons, they're going to perform these tests under anesthesia, which increases their diagnostic accuracy, but obviously the patient's awake when we're doing these tests. And then the best special tests for the PCL are the posterior drawer test for straight plane posterior instability and the sag sign. The posterior drawer test is graded by the amount of posterior translation present and the end feel, And then the sag sign is graded either as positive or negative for if there's a sag sign present or sag sign absent. Special tests for the collateral ligaments are the valgus stress test for the MCL and the varus stress test for the LCL. Varus or valgus stress is applied with the knee positioned in both 0 and 30 degrees of flexion, and the test is positive when it reproduces either familiar pain or laxity. And a positive finding of increased laxity at 0 degrees of knee flexion indicates a major disruption of the knee, with one or more rotary tests usually also being positive. And the patients may also present with tenderness to palpation at the MCL or the LCL. As I discussed earlier, the major mechanisms of injury for the ACL involve cutting, sidestepping, or jump landing. So jump landings, they can be either double leg landings, like those that frequently occur during basketball, or they can be a single leg landing, like those that frequently happen in sports like European team handball, if you've ever seen that. Now, a commonly observed characteristic of ACL injuries is a rear foot strike with the knee in nearly full extension. And athletes that tear their ACL are also frequently off balance, and they may have been bumped by another player, or there simply just may be another player close by. However, all knee injuries may be partial tears, complete tears, or avulsions. And in pediatric patients, the ACL injuries that may present as a tibial spine fracture, as at that age, the ligaments are a little bit stronger than the bone. All right, this is a picture that shows the impressive amount of subluxation of the tibia that's going to happen immediately after the tear of the ACL. The sister of this player was the one who took this picture. She had an MRI that showed she had an ACL and a medial meniscus tear and eventually had an ACL reconstruction. So you can see circled her knee position there and how much her tibia has subluxed anterolaterally at the time of the injury. So that's a pretty cool picture. All right, so some of this obviously is not on the exam, but just gives you an idea of some of the mechanisms surrounding ACL injury. So this is a video of a double leg landing. So you'll see if you'll concentrate on the top left video, kind of shows it best. How at that impact time, her knee goes right into that valgus type position. So that's what we're seeing here. And you can see, kind of compare it to the other frames, other videos where you can see the different positions, but you can see players are close around her. You know, maybe she did get bumped a little bit when she was landing. So that's a mechanism for a double leg landing. So here we have a mechanism for a single leg land, or I'm sorry, a plant and cut. It's on here. There you go. So the player in blue is the one that's being injured, the light blue. And look at his right leg and how he's kind of knee extended. There's a little bit of a rear foot strike. He's leaning kind of forward, and then that knee collapses inward into that valgus position. And so this is the kind of picture that breaks it down frame by frame. So in A, he's running at high speed towards the other player. At B is that initial contact where he strikes with his right heel and makes a sidestep cut in an effort to reach the ball or tackle the opponent, but he doesn't get there. And then you can see in C and D where we get that entire load of the left leg and then that dynamic valgus position. All right, now here we have a single leg landing. This one is occurring in soccer. It's the player in yellow that gets injured. It's the right knee that's being injured. Kind of doesn't look like that much initially. Um, But when you break it down kind of frame by frame, so the first one here, they kick the ball with their foot, and then now as they strike at initial contact, the trunk is kind of rotating to the left, and he's kind of off balance backward, puts the entire load on his right leg here in C, and then his right knee collapses, is abducted, and the ankle joint is an eversion, which is termed that dynamic valgus, but he doesn't kind of collapse into it at this point. All right, now skiing has a lot of different mechanisms that are way different from like other sports. So this one, they're just kind of cool to watch though, because it's pretty crazy how fast they're going and what happens when they hurt themselves. So it happens so fast you hardly even notice what happens. And so this video is kind of cool because they'll slow it down a little bit. And what you can see, you saw a little bit there, you can see that his right ski becomes elevated from the snow. So right there, his right ski is off the snow. He reaches to reestablish contact, And then that knee right away when it grabs, it kind of pushes him back into that valgus, flexion internal rotation position. So that is the called a slip catch type of pattern. So right there again, knee's pretty straight. It gets jammed right back up when he catches that snow, and there it goes, and he's done. All right, and so the next one, so this is just a frame by frame of that, and we can see, that dynamic valgus moment right there in that frame. All right, so we're going to discuss some diagnostic accuracy of some of the special tests for the knee here in a second. But before we do that, let's just quickly review sensitivity, specificity, and likelihood ratios. So sensitivity is a test's ability to obtain a positive test when the target condition is truly present, and that's a true positive. And we use the mnemonic SNOUT, so a sensitive test where the negative result helps us rule out a condition. And the formula for sensitivity is true positives divided by the true positives plus the false negatives, or A over A plus C. So specificity is a test's ability to obtain a negative test when the condition is really absent or a true negative. We use the mnemonic SPIN, so in a specific test that's positive, it helps us rule in a condition. And then the formula for specificity is the true negatives divided by the false positives plus the true negatives, or D over B plus D in our 2x2 table. So notice that tests with high sensitivity have a small number of false negatives, and tests with a high specificity have a small number of false positives. But the weakness of sensitivity and specificity is that they're influenced by the prevalence of the condition. So likelihood ratios, they tell us the probability a patient has the condition after the test is done, and they're independent of that disease prevalence. And the formula for a positive likelihood ratio is sensitivity divided by 1 minus the specificity. And the formula for a negative likelihood ratio is 1 minus the sensitivity divided by the specificity. And tests with small negative likelihood ratios can be used early in the exam to rule out alternative diagnoses. And tests with large likelihood ratio, positive likelihood ratios can be used later in the exam to rule in the primary diagnosis. So let's use the example nomogram here on the right. For a condition with a pretest probability of 30%, a negative test result and a test with a negative likelihood ratio of 0.2 yields a post-test probability of 5 to 6%. Now, alternatively, if you have a positive test result and a test with a positive likelihood ratio of approximately 3, you're going to have a post-test probability of almost 60%. So you can see how just applying one test will change your odds of whether the patient has the diagnosis or does not. All right, so this is a table from the review and study guide. It shows in the red boxes that are going to come up here the best tests for ACL injuries. So the Lockman test is the best for one plane anterior instability with good sensitivity, specificity, and likelihood ratios. Now the anterior drawer test, that's more specific than sensitive, with a better positive likelihood ratio than a negative likelihood ratio. And this means that while a positive test increases the probability of an ACL injury, the negative test is not as meaningful. The pivot shift test is the best test for anterolateral rotary instability. And as I said previously, it's difficult to do. A lot of times you can't even do it on the patient. So the sensitivity and likelihood ratios are much better when the test is performed with anesthesia than when it's performed without anesthesia. And you can see that there on the slide. Now, despite the fact that the Lockman test is the best test for integrity of the ACL, I found that with interns, residents, and fellows, it's frequently performed and interpreted poorly. And shown on this slide are the two most common methods for performing the Lockman test. So in his textbook, Orthopedic Physical Assessment, McGee describes 8 different modifications of the Lockman test to account for anatomic variations in both the examiner and the patient. But regardless of the method that you use, the principles remain the same. So the knee should be about in 20 to 30 degrees of knee flexion. With the femur stabilized, the PT should translate the tibia anteriorly on a plane that's parallel to the tibial plateau. And a positive test is indicated by either a soft end feel or excessive tibial translation when it's compared to the uninvolved extremity. Now, according to McGee, disappearance of the infrapatellar tendon slope is also a positive finding. And also, according to McGee, a false negative test may be the result of not properly stabilizing the femur, could be a flip bucket handle meniscus tear that blocks translation, or if the tibia is medially rotated. So the posterior drawer and the sag sign are two of the best special tests for one plane posterior instability. These tests have not been studied as extensively as the ACL tests, and based on the best available evidence, both tests appear to have good diagnostic accuracy. And tests for medial instability have been studied with enough frequency to assess their diagnostic accuracy, and both positive and negative test results accounting for both pain and laxity are going to result in moderate shifts in probability for medial instability. However, the varus stress test has not been evaluated formally, and it's likely due to the relative rarity of isolated LCL injuries. So it's important to also assess physical performance in patients with knee ligament sprains. Hop testing is a practical physical performance measure that assesses strength, neuromuscular control, and confidence. And single leg hop tests are the most common hop tests that are utilized to assess baseline pain, function, and disability, assess symmetry with regard to the unaffected limb, evaluate the patient for return to activity or sports, and to also evaluate the effectiveness of treatment programs by measuring changes during treatment. There's many forms of these single leg hop tests, including the single leg hop for distance, the crossover hop for distance, the triple hop for distance, and the times 6 meter hop. Those are probably the four most common ones. You should also use validated patient-reported outcome measures when they're appropriate. So to assess knee symptoms and function, you should use the IKDC or the International Knee Documentation Committee 2000 form. The Knee Injury and Osteoarthritis Outcome Score, what's also known as the KOOS. Or you could also use the Ligament knee scoring scale. To assess activity level, you should use the Tegner scale or the Marks activity rating scale. And the Tegner scale groups activities into levels based on their degree of stress on the knee. So level 10 is competitive elite level sports, and level 1 is sedentary work. And the Lisham and the Tegner scales are frequently utilized together. After ACL injury, assessment of psychosocial factors is also important. The ACL Cruciate Ligament Return to Sport Index, or the ACL RSI, assesses psychological factors that may hinder return to sports. There are many interventions available for the rehabilitation of patients with knee ligament sprains. For this presentation, we're going to focus on those interventions that were rated as having A-level evidence with a strong recommendation in the clinical practice guidelines. And you'll see the language in the clinical practice guidelines say that you should do these things. So to increase muscle strength and performance after ACL reconstruction, both weight-bearing and non-weight-bearing concentric and eccentric resistance exercises should be started within 4 to 6 weeks. These exercises should be performed 2 to 3 times per week for at least 6 to 10 months post-operatively. If a patient with an ACL tear is treated non-operatively, I think you can use similar recommendations, although that was not included in this guideline. Also not included in this guideline, it's been my experience that patients may need to continue to perform these exercises on their own for even up to 2 years after surgery. After ACL reconstruction, muscle inhibition is a very frequently encountered problem. Neuromuscular electrical stimulation, that should be used for 6 to 8 weeks in conjunction with muscle strengthening exercises. And there have been a variety of parameters studied with effect sizes ranging from small to very large, depending on how they did it. In patients with knee stability and movement coordination impairments after knee ligament sprain, which is almost every patient, right? So neuromuscular training should be incorporated along with the muscle strengthening exercises. And neuromuscular training incorporates three-dimensional movements of progressively greater speed and difficulty while emphasizing proper jump landing and balancing techniques. Examples of this may include static and dynamic single leg balance exercises, single and double leg jump landing progression exercises, and trunk stability exercises. All right, so let's transition now to the meniscal and articular cartilage lesion clinical practice guidelines. So we'll talk a little bit about background here. Injuries to the menisci are the second most common knee injury, and they account for almost 1/4 of all the injuries. They frequently occur in a combination with ACL injuries as well. Older people, they have a higher incidence of meniscus tears in general, and medial tears specifically compared to younger people. Younger athletes are more likely to have lateral injuries, and then risk factors for chronic meniscal tears are greater patient age and increased knee laxity after ACL injury. Cutting and pivoting sports are risk factors for acute meniscal tears. And while the rates of meniscal surgery have increased over the past decade, recent research has shown that patients who are given non-operative treatment have similar outcomes to those who undergo surgery. In younger patients, meniscus repair is preferred over meniscectomy because it preserves the health of the articular cartilage. The prevalence of articular cartilage lesions in athletes' knees ranges from 27 to 59%, although a lot of these are asymptomatic. And articular cartilage injuries frequently occur after partial meniscectomy or after a second ACL injury. A major risk factor for articular cartilage injury is the presence of a meniscal tear. And although return to activity after articular cartilage injury and surgery is high, failure and reoperation rates are also high. And female sex, older age, higher BMI, longer symptom duration, prior surgery, and lower self-reported knee function are associated with higher failure rates after articular cartilage repair. The most common mechanism of injury for an acute meniscus tear is a twisting injury. Chronic meniscal tears and articular cartilage lesions do not have a typical mechanism that produces an injury, and the patient may not even remember a specific traumatic event. Patients with articular cartilage lesions frequently report that their symptoms are aggravated by repetitive impact activities like running and jumping. In the subjective portion of the exam, patients with acute meniscal tears describe feeling or hearing a pop at the time of the injury, but they report delayed effusion with onset 6 to 24 hours post-injury, and that's compared to the ACL injury where the onset is immediately, like within a couple hours. Patients with articular cartilage lesions describe intermittent pain and swelling. Now, if an osteochondral fracture is present, the patient may describe acute trauma with a hemarthrosis. And patients with both meniscal tears and articular cartilage lesions report knee locking and catching. Now, as stated previously, in the objective portion of the exam for all knee injuries, you should assess knee joint range of motion, effusion, thigh muscle strength, and lower extremity movement coordination and knee stability. In patients with meniscal tears, they're going to frequently have pain when overpressure is applied to the end range of knee flexion or extension. And patients with both meniscal tears and articular cartilage lesions have tenderness to palpation at the affected joint lines. So there's some additional special tests that you can use to diagnose meniscal injuries. The two best ones for meniscal injuries are the McMurray test and the Thessaly test. Both of these are pain propagation tests. So for the McMurray test, the lateral meniscus is tested by passively internally rotating the tibia while extending the knee, while the medial meniscus is tested by externally rotating the tibia while extending the knee. Now the Thessaly test, that's performed with the patient standing on the involved leg and rotating their body and leg internally and externally. And the test is repeated with the knee in both 5 and then 20 degrees of knee flexion. A positive finding in both of these tests is reproduction of a click or pain in the knee joint in the same area as the patient's chief complaint. Now, much like with low back pain, imaging findings of meniscus tears, they're very common in asymptomatic individuals, especially as they age. Now, prevalence ranges from approximately 5% in younger ages and up to 67% in older ages. There's a variety of tear patterns present. The type of tear and the age of the patient influence the choice of interventions. Radial tears, they're the most common, but they have poor capacity to heal because they mostly occur in the area of the meniscus that's avascular. And parrot beak tears, they're different from radial tears in that the tear is curved like a parrot's beak. Vertical or horizontal tears involve disruption that's parallel to the circumferential fibers of the meniscus, and those tears are usually repairable. Bucket handle tears, they're a form of a vertical tear where the torn piece of the meniscus is displaced. And these tears may flip displaced tissue into a variety of areas in the joint, potentially creating a blocked motion. And if this occurs, surgery is warranted acutely to prevent loss of knee motion. Flap tears are similar to bucket handle tears, except they do not involve the full thickness of the meniscus. And then while acute tears are from excessive force applied to normal tissue, degenerative tears result from repetitive normal forces applied to abnormal tissue. And degenerative tears typically have a complex tear pattern, as you see in this one right here. Now, the incidence of each tear pattern is also different based on patient age. In younger, more athletic patients, acute tears are more common and often bucket handle tears, as shown in that top red circle. Chronic meniscal tears are more common in older individuals and are often more degenerative tears, as shown in the lower red circle. And as stated previously, the recent evidence suggests that non-operative treatment is equivalent to surgery for these kind of degenerative tears. So here's another table from the review and study guide and showing are the best individual tests for meniscal tears along with the diagnostic accuracy for a combination of tests. So the McMurray test and the Thessaly test appear to be somewhat more specific than sensitive. Therefore, the presence of a positive test appears more useful to rule in a meniscal tear than a negative test is useful to rule out a meniscal tear. Combination of tests, they appear to be better than the individual tests in the diagnosis of meniscal tears. And each combination includes joint line tenderness and adds other elements such as the McMurray test, the Thessaly test, joint effusion, knee flexion overpressure, and the squat test. And just as with knee ligament sprains, it's important to also assess physical performance and self-reported function. The recommendations here, they're no different from those that we discussed previously, so I'm not going to review them again. Now, as with knee ligament sprains, there's many interventions available in the rehabilitation of patients with meniscal and articular cartilage lesions. And as there's not much research on interventions as there was for knee ligament sprains, we're going to focus here on those interventions that at least have a B level evidence with moderate recommendation in the clinical practice guidelines. But again, even in the clinical practice guidelines, they still use the language should do when they're describing these interventions. So progressive active and passive knee motion may be utilized early in the rehabilitation of patients after both meniscal and articular cartilage surgery. And post-surgical rehabilitation guidelines typically limit end range flexion and meniscus repairs. Following articular cartilage surgery, you should use a stepwise progression of weight bearing. So full weight bearing should be achieved within 6 to 8 weeks. And this may be achieved with the patient non-weight bearing for the first 2 weeks, then partial weight bearing at 25% for 1 week, 50% for 1 week, 75% for 1 week, and finally full weight bearing at 6 weeks post-surgery. So as with most musculoskeletal conditions, therapeutic exercise is the mainstay, and you should prescribe supervised progressive range of motion exercises and progressive resistance training for both the knee and the hip muscles. Neuromuscular training that includes static and dynamic balance exercises and plyometrics should also be included. And then neuromuscular electrical stimulation is an adjunct that may be utilized. Following meniscus repair surgery, you should utilize this to increase quadricep muscle performance and knee function. And again, optimal parameters are not really well known, but you can use the evidence that exists for ACL reconstruction as a framework. And lastly, you should use supervised rehabilitation programs after arthroscopic meniscectomy, and also provide and supervise the progression of a home-based exercise program, providing education to ensure the correct exercise performance. Now, fractures of the fib, or patella may occur with traumatic injuries to the knee. So the Otto and knee rules were developed and validated to assist clinicians with the decision to order radiographs when a patient has an acute traumatic knee injury. The Otto and knee rule has a sensitivity of 0.99 and a negative likelihood ratio of 0.05, which means that a negative test effectively rules out a fracture of the knee. So radiographs are recommended with patients who are age 55 or older, demonstrate isolated patellar tenderness without any other bone tenderness. They could demonstrate tenderness to the fibular head. They're unable to flex their knee past 90 degrees, or they're unable to bear weight immediately after the injury in the emergency department. So if they have any one of those elements, you should order a radiograph. It's important to remember that these were developed in adults, not children. So you just can't apply these in children. So you'd be much more likely to order a radiograph on a child than using these rules. So multi-ligament knee injuries are not as well studied because thankfully they don't occur as frequently. So one of the classic multi-ligament knee injury patterns is called the terrible triad or the unhappy triad that's shown here. Um, O'Donoghue in 1950 called attention to what he called, quote, that unhappy triad of one, rupture of the medial collateral ligament, two, damage to the medial meniscus, and three, rupture of the anterior cruciate ligament. So that's the classic description. Curved evidence kind of also lumps the lateral meniscus injury in there as well, so it's not as clear cut as involving the medial meniscus. The injury is often the result of a direct blow to the lateral or anterior lateral leg, or the knee, with the knee in nearly full extension. That's what we see in the photo of Tom Brady when he was playing on this slide. So current evidence expands this injury pattern, like I said, to other tear patterns. So thankfully, these knee injuries are not they don't happen frequently. Knee dislocation is the worst case form of a multi-ligament knee injury, and it requires careful evaluation to avoid serious and potentially limb-threatening complications. And the most serious complications are injuries to the popliteal artery and the common peroneal nerve. So when I was at West Point, like 4 or 5 years ago, there was a case of a gymnast who was doing just some training on a trampoline, and injured his knee landing on the trampoline. The athletic trainer that evaluated him at that time, evaluated his knee, thought that he was kind of okay. He was supposed to see a physician as a follow-up the next morning, but he went back to his room that night. His knee swelled massively. He got to the surgeon the next morning, and um, he had had a either a subluxation or a some sort of kind of instability, multi-ligament knee injury to the knee that had disrupted his popliteal artery. And so now a lot of his, tissue below that was like necrotic from lack of blood supply over the night. He ended up losing part of his foot. So these can cause long-lasting problems that can cause people to lose their legs. But they only comprise about 0.2% of all orthopedic injuries, although the actual incidence is difficult to estimate because the knee often spontaneously reduces after dislocation, like it probably did in the case of that cadet. Both the high injury mechanisms, such as motor vehicle accidents, and then low energy mechanisms, such as those that occur with contact and collision sports, or again, like this cadet, like jumping on a trampoline, those can all cause knee dislocation. So it could be like a major thing or a relatively minor thing. The mechanism is typically hyperextension with either a varus or a valgus load. Estimates of the incidence of popliteal artery injury range from 4 to 65% in knee dislocations, and then unrecognized damage to the popliteal artery can result in amputation, like I described. The incidence of peroneal nerve injury is in knee dislocation is estimated to be 20%, and the location of the injury is frequent where it passes around the proximal fibula, around the fibular head. And recovery of nerve function is poor and may result in chronic foot drop. So the peroneal nerve, you should remember what does it innervate? It innervates the anterior compartment of the leg, ankle dorsiflexor, so you lose foot drop, and they now going to require long-term use of an ankle foot orthosis. So not good. All right, so that's the formal part of the talk tonight. And so what we'll do at this point is I have a few review questions that we can go over. And I'm going to start a poll here. What I'll do for this next part, I'm going to throw up a question, and I'm going to start a poll for you guys to answer. So you guys can go ahead and take a minute to think about it and put in the answer that you want. And then we'll go over kind of the key points to the question and what the answers are. So here's the first question, and I've launched the poll. So go ahead whenever you kind of are comfortable with your answer. Go and put that in there. And once everybody's kind of chimed in here, I'll give people about a minute to 2 minutes. Take about another 10 or 15 seconds or so. All right, so let's go over the results. So here's the results. So everybody chose letter B. So let's see what we got there. So key points of the question are in red. So I think the joint line tenderness and the delayed effusion is the two main points. And so that would lead us to suspect a meniscus injury. So what tests do we have? So you guys were absolutely correct. The McMurray and the Thessaly tests are the correct ones for diagnosis of meniscus injuries. So these two, they are for straight plane anterior instability of the knee. Noble compression, that one is for IT band friction syndrome, and Eli's test is evaluating quadricep flexibility. And then the varus and valgus stress test tests the MCL and the LCL respectively. So good job with that one. So yeah, the correct answer is B. All right, so now I'm going to relaunch the poll. You guys can take another minute and put in what answer you think is correct. Take another 20 seconds, 20, 30 seconds or so. All right, let's see what we got. So you guys should be seeing the results. Most people chose B, but we had some A's and C's. So let's hit first the key information. So it's an acute knee injury, so it's a traumatic injury. The patient fell up the stairs, so they hit the front part of their knee, so anterior proximal tibia, on the step. And then they had bruising around their tibial tuberosity, which kind of tells you about where they hit their knee. Kind of sounds like very similar to what you would see in a car accident, right? So the correct answer is a sprained or ruptured posterior cruciate ligament. So this not as common. I tried to, the easy question would be they got in a car accident and the dashboard hit their knee, and obviously I just told you about that like 15 minutes ago, so it would be an easy one. So I was trying to think of some different ways. I had a cadet at West Point, a female lacrosse player that was doing summer training. She had a big heavy backpack on and she fell on the front part of her knee, like running uphill, that caused a posterior cruciate ligament injury. So it does happen. So it's not completely out of the realm of possibility. But the ACL, that's the opposite mechanism. So instead of the tibia being forced translation posteriorly, anterior translation. So that's not the ACL. Patellar dislocation. Not probably out of the realm of possibility, but just not as likely. So this is a very common thing that you'll see on the board exam is that these kind of most likely things. So although that's technically possible, patellar dislocation, it's much more likely to be this posterior cruciate ligament injury based on the information that was provided. And then obviously we didn't have a severe enough injury for a rupture of the popliteal artery. So that's that one there. All right, so we have one more, I think. Yep, this is the last question, so we'll relaunch the poll here. So take a minute to take a look and see what choices you want. If you're having trouble with this one, think a little bit about the knee anatomy. So it kind of goes back to what's the knee anatomy and what kind of things does the medial meniscus attach to? Take about another 30 seconds or so. right, so looks like everybody put an answer in there. So here's the results. So we got C and D were the most common answers about. So let's go through the key information. So the obviously the key piece there is it's a medial meniscus repair procedure. And then what exercise should be avoided for the first 6 to 8 weeks? So acutely after the surgery to protect the repair. So kind of think about what other things attach to the medial meniscus. And so one of them that does attach to the medial meniscus is the semimembranosus muscle. So you would want to avoid open chain resisted knee flexion. Now they can do like open kinetic chain, like knee range of motion exercises, but we're talking about like a knee flexion machine, talking about like putting a 10-pound ankle weight on their leg and doing kind of resisted knee flexion in that position. And then, these are all kind of fine. They don't do anything that would do anything to kind of compromise that medial meniscus repair. So that's that. All right, so that's all I have for y'all tonight. But I'm happy to answer any questions that you guys have. Based on experience doing this previously, the best way to do that is if you would type your question into the chat box. And what I'll do is I'll repeat it to the group and then hopefully answer it to the best of my ability. So if anybody has any questions, go ahead and put those in the chat box right now. So I had one question here is could you explain the Eli's test a little bit more? So Eli's test, the test for your rectus femoris and quadricep flexibility. So the patient is prone. You hear it called a prone knee bend test. And so the patient is prone. You simply stabilize the pelvis and flex the knee. And you're looking for either asymmetry or just general lack of ability to flex the knee. So they should be able to almost get their calcaneus to their butt, and if they can't do that, then they would be a little bit tight with their quadricep muscles. So next question is go over the sensitivity and specificity again. So of course, yeah, and that's can be a hard concept to get. So let me put this slide up here, and I'll explain it a different way too than I explained it the first time, because sometimes I think it's helpful. So if you look, it all comes down to this 2 by 2 table. And let's say you're doing the test and you have some way the truth to measure the truth. And so the truth could be measured by like an X-ray, the truth could be measured by an MRI, by surgery, by some test that makes you know the truth. And then you have this other test that you're looking to know if it kind of tells you the truth. So let's use fracture and the Ottawa knee rules as an example. So we have the truth is that they have a fracture or don't. So they have a positive or a negative X-ray. So in a sensitive test, so we want this test to be sensitive because we don't want to think that they don't have a fracture when they really do. And what does that mean? We want to know that they have a low number of false negatives. And so that is the specificity. It deals only with the people that have a fracture. You're not getting any or very few false negatives with that test. Then the specificity is the opposite. So a negative test means that there's not a lot of these. That means that negative test is really, really useful. So here in a positive test, so a specificity, it's D over B plus D. Because this is really small, the false positives, it lets us know that if the test is truly positive, because there's so few false positives, we can be really confident that they have whatever condition. So coming back to those two mnemonics, spin and snout. So snout, a sensitive test. If it's negative, so if it's negative, they have a sensitive test has a low number of false negatives, so you can be pretty sure they don't have whatever thing that you were looking for. And the same thing with specificity, spin. So specific tests have a few number of false positives. So if the test result is positive, you can be really confident that they do have the condition. So hopefully that explains that better. Um, Okay, so one question here was, does literature show that NMES is best for either ACL or meniscus injuries compared to blood flow restriction therapy for early phase rehab? There's actually, I've been in this long enough to see kind of trends kind of come and go. Blood flow restriction is one of those trends that's kind of come up. It does need to be researched a little bit more. But I think at the current point, the stronger evidence is for NMES. Um, Probably in the ACL. There's not as much in the meniscus injury literature because it's just not as much studied. But definitely for the ACL, the NMES is what's kind of like current best evidence. Now, that doesn't mean that you can't use blood flow restriction therapy, but especially early on, I mean, there's a little bit more nuance than that was in this presentation. Neuromuscular electrical stimulation, like it should be done kind of like not early, but within the first couple weeks, but not like very acutely. And then it should be done for like 8 to 12 weeks afterwards. So I know early or in my career, I was stopping it a little bit sooner than what kind of the best evidence is for it now is to do it a little bit longer. And that's because after ACL injuries, the muscle inhibition is a huge factor and it can create this kind of long-term strength deficit. So I definitely do use blood flow restriction therapy, but I've started to use the NMES a lot more starting at about week 1 or week 2 after their surgery. Let's see. Other question I had here was, what's the best way to get rid of painless knee popping with full weight bearing squatting, and what could be the cause of the popping? So, and not to be like a glib, but the best way to get rid of it is to ignore it because it's kind of always going to be there. As long as it's painless, it's probably harmless. It could be from a number of different things. There could be some soft tissue like bowstringing and crepitus that could do that. It could be from just kind of some inconsistencies in the surfaces, the articular cartilage in that area. Um, yeah, and it could be a number of different things, but as long as it's not painful, you can reassure the patient, whoever you're talking to, that it's not a big deal. But yeah, most likely caused by either soft tissue crepitus or by like just some, kind of gritty surfaces of the articular cartilage. All right, so if anybody else has any questions or if I didn't answer your question sufficiently, please let me know. I'm happy to kind of answer any orthopedic question. Don't ask me anything about neuro. Anything ortho, I can answer as well. All right, seems like everybody's had all their questions. I really want to thank everybody for signing on here tonight. I hope you got some good information out of it. Good luck whenever you're taking the exam, either in January or out into the future, and hopefully look forward to working with you guys as colleagues over the next year or so. So have a good night and take care.